Welcome everybody to our GPReady event this evening. Great welcome to you all. Thank you for joining us on this autumnal Tuesday night. Welcome, thank you for giving up your time. My name's James Waldron. I'm a First5 GP and the co-lead for Nottinghamshire for the Vale of Trent. And I'm also First5 co-lead community. And I'd just like to extend the welcome to you today. GPReady is the Royal College of General Practitioners program of events and content designed to help you guys, designed to help First5 GPs survive and thrive in the profession, especially in this really challenging time that we find ourselves in. So we feel it's even more important. The aim of this session is to provide you with an insight into the future of general practice. But where we're going to do things a little bit different to previously is we're going to put the role of First5s in the centre of our talk, and we're going to be really driven by your questions and your concerns and your queries as we go through this. So please feel free to contribute, and that way we can make the content as relevant as we can to you and your needs. We've got a fantastic panel of speakers today, and we're going to ask them to share their views on the future of general practice and the roles that they believe newly qualified GPs play and will go on to play in the future. So we really want to hear what you think. Feel free to put your comments in the chat. Use the Q&A function as well. If you want to ask a question, put it in the Q&A, and we'll endeavour to get to as many as we can during today. But if we don't, or if they don't, if we can't quite fit them into today's agenda, we're going to look to put them into a blog after this and make sure that that we address everybody's questions and requirements. So without further ado, I'd like to introduce, or I'll let our panel introduce themselves. So just first off, Dr. Richard Fieldhouse.
Hi, thanks everybody for coming along tonight. Don't want to take you away from All Creatures Great and Small and Bake Off, which is starting later on. So I'm a GP locum. I've been a locum for 25 years in 100 different practices, up to 35 a year. I set up the National Association of Sessional GPs, which is a membership organisation for GP locums. We have got 5,000 members. We started off the GP Locum Chambers model, and we've just launched a fantastic free membership offer for newly qualified GPs who are RCGP members with the RCGP.
Fantastic. Thank you, Richard. Dr. Matilda Esan.
Hi everybody, I'm a newly qualified salary GP, started in August with an interest in medical education.
Fantastic, thank you. And Dr. Sonali Kinra.
Hi everyone, good evening. I hope you managed to get something to eat and drink. I'm a salary GP, I work in London. I completed my CCT 12 years ago. I've been a GP partner for 10 out of those 12 years, and I moved to London in January. Prior to that, I had been working in Nottingham, so the same area as James, and we worked quite closely together. I continue in my role as the GP retention lead for the Nottinghamshire Integrated Care System. And I've made, as I said, just a transition from partnership to salaried. So happy to take up any questions around that if you want, but I hope we all have a good evening.
And also recent success and appointment, is that right, Sonali? Yes,
recently elected to the RCGP Council. I started that role in November. So yes, please feel free to fire any questions. I may not have all the answers. Jodie's probably had more experience than me on the council, so hopefully she'll pick up those.
Thanks so much, and congratulations, Sonali. And then Dr. Jodie Blackadder-Weinstein.
Hi, my name's Jodie Blackadder-Weinstein. I was the First5 chair up until last year. I've been off on maternity leave for the last sort of 10 months, returning back to practice to a completely different world from what I left. So I kind of got a bit of a peripheral view and oversight of what's been going on over the last few months. I'm also a sports medicine doctor for a football team. So we've had some very interesting COVID related testing every single week for months now. So yeah, thinking about sort of how private medicine has dealt with COVID versus the NHS has been quite interesting. But yeah, happy to kind of take sort of any questions around future GP from being in the college for a little while. But then I'm also an RAF doctor, so looking at sort of different career options for sort of newly qualified doctors as well.
Thank you so much. Well, I think we've got a wonderful panel for you today, so please make use of them and ask your questions. Please keep them coming. So a lot of us here are First5 GPs, but if you're interested in being part of the First5 network, either locally or nationally, please get in touch with us at the rcgp.org.uk/First5. In a lot of parts of the country, there is this support system available and support with First5 GPs. And it's an invaluable support system, so please make use of it. And you probably hear a little bit about that as we go through. So now that we've kind of got some of the formalities out the way, let's get started. Just, I suppose, to start us off with, I suppose we address the elephant in the room, and that would be the pandemic. It's really brought to light the need to sort of help see where our role is as First5s going into this, and see as our role is going into this world of work and how we might develop it. Richard, do you have any thoughts about how people entering into the workplace at the moment might be affected, might be able to contribute to?
Yeah, probably feeling quite terrified, thinking, what on earth have I signed myself up for? It's obviously, it's a really exciting time, which is, I believe, an insult in China, isn't it, to say have an exciting day. So at the moment, I mean, what we as an organisation found going into the pandemic, completely not expected, not what we thought was going to happen, despite that we had NHS England on the phone to us all day, every day for days on end about planning a massive recruitment exercise to get as many GP locums into practices as possible. The absolute complete opposite happened. Appraised all holiday, CQC, everything was cancelled, all leave cancelled. So guess what? No locums weren't needed, and a lot of locums noticed first thing was this sort of epidemic of cancellations, and you've probably heard stories about locums having to sign on and some even worrying about being evicted because there's been such an incredible lack of work. Lots of locums, we understand, have now signed up to do salaried jobs, so it's been brilliant in many ways for practices filling vacant salaried roles, but although they were unattractive in normal times, so it'd be interesting to see what happens because of that. But there have been a lot of upset locums. I think things are now are coming back to normal. We in NESGP, we've got our own online locum booking system, and where we have locum chambers, certainly we're seeing lots of a big uptick in activity there. So things are starting to happen. And even today's announcement with CQC wanting to go back into your practices over in the next month, that's all going to change. But I'm just talking about just day-to-day work here. In terms of what the future landscape of general practice is going to look like, we've all had to absolutely hit the ground running with IT, with some amazing successes, but not necessarily done in a very scientific way, in a way that we would have planned. And it will be very interesting to see again what the research is going to show in over the months and years to come. I'm particularly concerned about risk management, and if we're going to see a big rise in complaints as the dust settles, we go into sort of next spring, summer, and there are all sorts of issues because of diagnosis and mismanagement, etc., because of telemedicine and the problems that might have. It's been a brilliant solution in many ways, but it could have also created some problems too. So there's lots to look out for there.
Well, I mean, that's really interesting insights. We talked a little bit before this meeting about the electronic changes and about the technology changes that we've had. Sonali, you've had some experience with that, with e-consult and the like. Can you tell us a little bit about those changes and how you've sort of been able to contribute to them?
Yeah, so in my practice in West London, we adapted to e-consult pretty quickly, and within the West London CCG, we are one of the practices, I think, with the highest number of e-consults that we are receiving every day. And I think what I was trying to emphasize before we came onto this call was about the variation that we have in practice, so that is across general practice, as well as the variation in patient presentation. I mean, that's why all of us actually, or many of us perhaps, join general practice because of the diversity of presentation of patients that we get, and it has its own challenges. What did we do? So I think we went through 3 phases in terms of adopting the online consultation within our practice. The first one was, of course, getting the process right in terms of, do we have enough people, kind of all hands on deck to be able to deal with the online consult? Did we set up some F12 templates so that we are all recording it in the same place, and that would help us to really do that data capture, so that, like what Richard said, that it, how many of our e-consults were getting converted into face-to-face, were getting converted into telephones. We wanted that data that was there. So one was getting kind of the back office and the process right. The second was about making sure that there were enough people on board to be able to deal with the e-consult. Are we really doing triage, or are we doing consultation? Because there's that clear-cut division between the two, and also then the time allocation varies with it. Third is about, what are you doing in terms of converting that to whether a face-to-face, a telephone, or a video consult. And then fourth, I think the most important of it is what's your outcome in terms of the patient? Has it led to prescription? Has it led to further investigation? Or have you sent a text and then the patient has been unhappy with that response, or that the problem hasn't been dealt with and it has led to another e-consult? So there are quite a few steps in that. When we started, we were all, because of the acute kind of the peak time, we were all triaging from a common list. So all the GPs, we didn't pay too much attention to the continuity at that time, because it was primarily acute presentations. So we had all GPs just picking up kind of one e-consult or whatever telephone call that was coming. The next phase we moved on, we tried to build in a bit more continuity, so that if the patients were asking for specific GPs, those online consultations were being added on to that general practitioner. Now, third, what we are finding is that we have to make that very clear cut, whether this is actually a triage or whether this is a consultation, because the time allocation has to vary, because we are seeing that there may be some burnout coming. We are seeing people burning out primarily because you cannot deal with an e-consult, kind of close the entire consultation within a 10-minute time. Sometimes it just can't happen. So I think any change that is there, though we had to quickly change overnight, the patients are still adapting to it. That's why we had those damaging headlines last week, which were in Telegraph and BBC, about general practice not being open. And the physical door may have been replaced by a digital door. And we have to find that kind of middle ground where it's not going to be all digital, because some people are feeling digitally excluded. There is the digital poverty that we know in patches outside, and we have to be mindful of that. This is not going to be one size fits all. And I think we just need to be cognizant of that as we go ahead planning in the future, whether that's during the second wave or second peak that we've got and beyond. We can't just be thinking about the next 6 months.
Thanks, Sonali. I think 2 things I picked up from what you were saying there is one about developing these resources and about how we might be able to contribute. And the other thing is about sort of the resilient aspect of the changes that we're going through, and not just electronically, but also as a profession. I mean, I wonder if we just pick up on the first part there and put to the panel, how do you feel that we can, as First 5 GPs, as early career GPs, contribute to the development of these new systems? And in what ways can we help to sort of shape the future general practice from an electronic point of view?
Can I comment on that, James, with an example, if that's okay?
Yeah, sure. So Sonali, and then on to Jodie.
Oh, sorry, Jodie, did you want to come in?
Just briefly, I think the benefit that you have as a First 5 GP is that you're new to the system, you've not been worn down by it, and sometimes that means it's sometimes not quite as phasing to deal with changes, because actually it might be the first time you're using systems. You're not thinking, oh, the system we had three iterations ago was better. So you just embrace having that sort of unfittered, fresh mind when you go to these practices, because actually that's often what's really needed when you're designing these systems. Obviously, listen to people who've had the experience. The experienced GPs have gone through lots of iterations and pick up on that. But the enthusiasm that you can bring for this new technology, this new way of working, can be just what our practice needs. So don't be afraid to kind of just take that sort of new puppy dog attitude into the practices, because actually that's often what is lacking when people are really, really tired.
Thanks so much, Jodie. Sonali, what were you?
Yeah, I was just going to say that our trainee, so once actually she had completed her RCA, she had volunteered to look into our e-consults that were coming. So, you know, when you're talking about process, she made it as her quality improvement project to really look into the data and audit so that we are able to plan our appointments ahead. So completely agree with what Jodie is saying there, that, you know, you bring in a fresh set of eyes, isn't it, to look at the new processes, and you can fine tune it as you go along, because nobody has this completely sorted out. So that's the good thing about it, that we can all kind of figure it out together and come up with whatever that is. But remember, it's an iterative process. It's still not going to probably be perfect, but that's fine. And we can just try to change things as we go along.
Fantastic. Thank you so much. Yeah, I think that we can really be on the spearhead of these things. And I suppose as broadly a technologically savvy bunch of people, and we can actually help advise. And this is an area of expertise that we can contribute to. I do wonder again about the resilient aspect of this and the changes tiring, and it can be quite hard. Matilda, as a newly qualified GP going into this salaried role, how have you found it, and how have you sort of helped protect your resilience going through these changes?
I think for me, I think the biggest shock was probably, you know, in April time, when it became very apparent that we weren't going to have a full waiting room again. And the fact that as a trainee, many of the practices that I worked in were mainly face-to-face. We didn't really do telephone consults. So it was kind of learning to be comfortable with the risk, you know, especially when you're dealing with small children, or when you're dealing with families who English is not the first language, or when, you know, you get that genuine sense that patients find it difficult to express themselves on the phone, and you're looking at the time and the time's just going down, down, down and down. So for me, some of the things that I have found is that we all probably know about the NHS 111 slots, and we have a policy that if the slot is not used, then it can be used by me or by, you know, reception to book someone in. So what I tend to find is if I've got, you know, like, so with language line calls, I don't know about anyone else, but I have to do 3-way calls. And, you know, the time it takes for you to actually get through to language line, it can take about 8 minutes. So some of the like little things that I've noticed is that language line is not actually very busy in the evening. So if I have a choice, I tend to get the receptionist to book that patient for the evening, because I know that I'm going to get to kind of quickly get through to language line and use most of their appointment for them. And then I think the other thing, now that we are kind of allowed to do a bit more face-to-face, is, you know, accepting when you can't do it on the phone anymore, because none of us want to go home worrying about that patient that we should have seen, or maybe I should have brought them in. So those are the kinds of things that I've been doing, and also going through my list in the morning and checking for any patients who have skin rashes, and sending one of my preset texts with the consent saying, you know, if you're happy and it's not in a sensitive place, please use the link below, so that actually by the time I get to the appointment, I don't need to worry about a pixelated video where I can't see the rash. I can just kind of give them their 10 minutes and look at the picture in real time. So those are some of the things that I've been doing, which have made my life easy. And definitely preset texts for COVID results. I've had a lot of those. I don't know about anybody else, but just a simple text saying your COVID test is negative. Please call if you want to discuss further.
I think finding these shortcuts and finding these ways of working through things, utilizing technology, is really important. I mean, quite a lot of this, it can be quite stressful, and it does really impact on it can really impact on our day-to-day well-being and the like, and actually finding support going into this is really, really important, and utilizing colleagues around you and the First5 networks as well. We've had a colleague who's been having who's asked a question, has been having a little bit of a difficult time in entering into this world of work, and entering into finding work in the area that they're in. Jodie, I think that you've put a few comments in there. Would you like to offer some advice into this?
Yeah, so we've got someone who just asked a question saying that what you've touched on, Richard, that because there's so few locum options available, so many people have gone into salaried jobs, and then actually now there's in some areas shortage of salaried jobs. So the person that's on here, Hope, has said, what is there to support me locally? So she's in the Midlands. So I've just sent her a WhatsApp group that we've got locally for lots of Midlands GPs, and quite often jobs come up on there. So that's an option if you are looking for work, because some of the formal ways of, it's a bit like when you're selling a house, sometimes things don't even get to the newsagents, so to the estate agents, sorry. So sometimes we've got groups coming up and jobs coming up in these groups that actually don't get beyond just word of mouth. So yeah, so if you are looking for jobs locally, it is really useful to actually get involved in some sort of virtual WhatsApp group, something similar to that, and be able to ask around, since we don't have the opportunity to face-to-face network like we used to. So if anyone else watching is in the Midlands, the link is on there as a reply. If you click on that, it'll take you to the WhatsApp group. But more generally, it is worth reaching out for if there's anything locally that you can join.
Brilliant. And in fact, the RCGP, so the First5 committee, in fact, did a series of webinars. Richard joined us for the first one. I'm going to come to you in a second, about supporting yourself as a locum, entering into the locum world at the moment. And there's a really good one on finding work. And you're absolutely right, Jodie. It's about, often the jobs don't make it to the, to the poster, if you like, and actually reaching out directly and building those links can be really helpful. There are, of course, other ways as well of addressing this as well. And Richard, would you like to expand a little bit on the ways that people might be able to access that work?
This is in terms of accessing sort of salary type posts, and it's a tough one at the moment. It's just all very fragmented. I was going to say something about these support groups with the Chambers network that have been going sort of 14, 15 years. These where local locums in a local area form a co-op collaborative and have regular monthly Balent groups. And these are usually in one of the locums' homes. They're scheduled to last 2 hours, but usually run for 3. Involves one of the locums cooking a meal for everybody, and that can get quite competitive actually, but fun. And those meetings I've always found traditionally very, very energizing, wonderfully so, to the point where then additional meetings, summer parties, Christmas parties, Skittles nights, pub quizzes and all that are organised. They're very energizing. You leave those Chambers meetings, having spoken to your local locums in the area, you will really, really get to know each other. And the next day you just feel great, and it's lovely. It's really nice. During lockdown, we've moved those online, and they can only go on for an hour because they're quite exhausting. And often in these meetings, we're talking to locums who are working in these various chambers, and they've spent the whole day doing online consulting, which they also say, look, it's exhausting. It's okay, you see a patient during the day, you can feel energized by it. They can energize you patients, but usually when it's over the phone or video, it's rarely energizing. They tend to all be draining. So having an additional hour of this exhausting video meeting once a month, once or twice a month, again, we find quite exhaust people. And research has been done into non-video type stuff like WhatsApp, which can be great in some ways, but they don't create any cohesion. They don't create any social cohesion. People you get to meet and become friends with, so-called on social media, whether it's Facebook, WhatsApp, whatever, they don't form the type of relationships that you would get actually in face-to-face meetings. So really excited, can't wait to go back to face-to-face ones. And ultimately, if you possibly can, when this is all over, and it will be, do get yourself hooked up with a bunch of local people who work in the same way you do, whether it's a bunch of salaried partners, whatever. do it. They can be absolutely fantastic. And because of that, you get it's lots of networking. We were talking before you guys all turned up about just one thing about e-consult and other things, and how, oh, that's for HEE and various schemes, and how actually completely fragmented information is in this world we work in, and it's the same with jobs, and a lot of it is who you know, and I don't mean that as in it's like a boys network. It's, if you're being a partner, I've been a partner, I was a partner for 6 months, never again. But it was, these are people, you spend more time with your partners than you actually do with your husband or wife, in many cases. And you've got to choose them. You've got to know them in all sorts of levels. So getting to know them socially, professionally, and especially when dealing with things like complaints, significant events, those are times when people are vulnerable, and that's the best time to get to know each other. It's a brilliant time to be able to help and support someone. And I'm not saying it's fun when someone else is suffering. I'm not saying that at all, but it does actually create a lot of sort of catharsis when you as a group of locums, let's say, can help support someone who's really feeling down. They come into the meeting, not wanting to make any eye contact, and by the end they're crying, they're laughing, they're so happy that there's been this watershed because of the support from their colleagues.
Yeah, fantastic. Thank you so much, Richard. I mean, I think, and I think there are other ways that people can address these sort of support aspects of it. First5 networks are a really fantastic way of doing that and plugging in, and at least locally we're still doing evening events. I do interesting pick up on what you're saying, Richard, there about the value and the benefit of meeting face to face. That's evidently become quite difficult and much more challenging. And especially meeting up with the colleagues and even having face-to-face consultations. I mean, I suppose just on sort of a lighter note, I mean, how have others in our panel been addressing that kind of change in social situations, like specifically during this pandemic? Anybody got any sort of great things that they've been doing to help support themselves? Sonali.
I'll come in, Jen. Yeah, so a few things. And I think this was also something that was touched upon by Michael West in one of the next generation GP meetings we had, was kind of the daily huddle. So at the peak of the pandemic, we were having virtual daily huddles, which meant kind of virtual meetings every day with almost the entire staff. And I think it was good, at that time, it was just a good time to touch base, just make sure everyone was okay. And one of the other things I've done on a personal level has been the looking after you too coaching. So this was a free offer from NHS England for anybody working within the NHS. And I've had 4 sessions with them. And I think it's the reason I think why it was good was just to kind of pause and reflect where you've been, what you've been through, and what you may, or where you may be heading. So I would certainly advise people to look at that as well. We have set up our own within the practice. We've got our kind of a coffee club WhatsApp group, but we have been, even if it is just for 5 minutes or 10 minutes, just to, pop your head into another person's room to just check how they're doing, or go up and send constant messages to each other to say, do you want a cuppa? So I never go upstairs to the coffee room, not asking others if they want to drink. And the same is reciprocated by all my colleagues. And I think just even if you send that message, I think just makes other people realize that you're there and they are there for you. So I would certainly recommend that. One of the other things we've done, sometimes kind of every few weeks, is bring in breakfast for the entire team. So again, just sending a message across to everyone to say, left some breakfast upstairs for you. And then of course, there's a bit of a run as to who gets there first. So I think there are a few things that you would do probably just with your regular friends, but just if you've not had a chance to meet your friends, then make your colleagues your friends, I guess.
Fantastic. And I think interesting thing, one thing that I would bring out of this is that whilst COVID has done immeasurable bad to the world, I think there are aspects of this that are that have actually brought out some good things amongst teams, and such. I mean, I know some practices would have had that kind of contact, but certainly more are doing that. And we had these morning huddles, we had these morning group meetings. And the other thing I want to pick up there is that you mentioned about mentoring, and I'm a massive advocate of that. And interestingly, something that is part of the New to Practice offer that is available to all newly qualified GPs in the first 2 years. And again, talking about bringing people together, this is delivered in different ways in different areas, but actually some of the more senior GPs helping to mentor and take some of the newer GPs under their wing. So please go and look for that locally. It is a part of a national offer that should be available to everybody. Certainly in England, I think in Scotland and Wales as well, but certainly in England. So, I mean, Matilda, you popped in the chat here that you found the mentoring quite helpful. Do you want to, I mean, if you'd like to share a little bit about what you found helpful about that, would be really great.
So I only did one session, but it was really, I think, things like mentoring and coaching in, you know, the GP world and doctors in general is kind of generally underrated. But it was really good. You know, before the session, my coach had sent me like some questions that they wanted me to fill out about what I wanted to get out of the session. And it was really nice. We just kind of had a chat about work, my goals, my concerns about starting, you know, a new job, a new practice, a new area. And it was really, really helpful. And I think all of us have probably received the email and it's been floating around and you kind of see it and you're just like, oh, I don't know what that is next. But I'd encourage everyone to go and dig in their mailbox. And it's really, unlike we were talking before about difficulties with signing up with things technologically, but that was one of the few things which I actually found quite straightforward. There was no faff.
Oh, excellent. So mentoring can be really helpful. I mean, Matilda, what sort of benefits, or and perhaps to anybody that's had mentoring here, what sort of benefits did you find having that time, you know, with mentoring, with coaching, has given to you?
I think for me, it was nice to speak to someone who wasn't a doctor and who wasn't my spouse or my friend, and just kind of get I don't want to use the word soft, but just get this kind of nice, neutral, objective overview. No one judging me, no one trying to like pick it apart or like force me to do this or that, but just very objective, focused, non-judgmental advice. So I think for me, that's what I enjoyed most about it.
Thank you so much. Anybody else want to share an experience they've had? Well, I mean, I suppose I had a particularly good experience with coaching at the beginning of my career. So not so long ago, just 2.5 years ago, when I came out of the VTS training scheme. I didn't exactly know where I wanted to go with respect to my career and what to pursue and how to get there. And actually, again, as what Matilda was saying, speaking to somebody removed from my situation to help me understand the problem and help to move forwards. And I think it's a really natural feeling for us all at the moment, especially when we are emerging into general practice that we never imagined, you know, a mode of general practice we never imagined we would be right now. I think it's natural to feel lost. I think it's natural to feel a little bit directionless, and something like that, and especially as part of a national offer, is a really good thing and something I would definitely recommend to anybody. Certainly recommend those things. So we've had a couple of questions come in and some of them sort of surrounding some of the changes in the technology that we've been having. And Zafar's asked, so telephone consultations versus face-to-face consultations in the next few years. Do we think that is something that's going to continue? Do we what's the panel's opinion about telephone consulting in I suppose in comparison to the traditional mode of face-to-face? And then you would like to answer that one, Jodie, especially because you will be coming into this not having the last kind of 6 months of development that we've been having.
Yeah, absolutely. So and Sonali's written a similar thing to what I was going to say, that we're in this state of flux at the moment because we've gone completely one way, And I know I've been going to my Keep in Touch days, and in I know in some practices, now patients are going completely the other way, probably not unrelated to certain letters that were in the press of saying, well, we really want face-to-face consultations. So are we going to then see a swing the other way, so that we do meet sort of a middle ground? I certainly find that actually there are some things I could have been doing either telephone or over video, and actually it works all right. And I was probably a bit reluctant to do that initially, and it's more convenient for a lot of my patients, and actually for them it's going to be really beneficial. But it has absolutely confirmed to me that there are some things that actually, and especially when it's some mental health stuff, people just want to see a person. And I think what COVID has done is made us face sort of head on what works and what doesn't work so well. I know it's just gut instinct for a lot of us at the moment because we've not got all the research to back it up in the long term. But we're gonna, I hope, come to this sort of middle ground where actually some stuff is going to be telephone, some stuff is going to be face to face, and then we can have that opportunity to see our patients, and that we need to, rather than just everything. The bit in the question which I think you've raised, which is really interesting, is does this need more GPs or less? And I think that's what sounds like quite a straightforward question, but then when you look at actually the system in which we work, are we wanting to see our own patients that we call back? Are we happy for someone else to see them if we're working from home remotely because we're not in public transport? There's so many wider questions about what is a face-to-face appointment and where do they come from, that I think not knowing how many GPs that's going to take is a good bit of analysis and modelling down the road. I think Richard's put his hand up there as well.
Yeah, it was kind of two things. We published on the NESGP an article recently from Victoria Chizu Brown, who's at the college, and she did a paper talking about how actually research out of Bristol was showing that remote consultations could take up to 30% longer, more time, more resources to do. So there's that workload implication. I don't think they're necessarily saving time. We're confusing empty consulting rooms and at the moment with telephone consultations. There's correlation, but I don't think that's causation. But I think far more importantly, going forward, with post-COVID retirement, we went into this 5,000 GP short. I suspect we'll probably come out with even a greater shortage. But I think more importantly, there's going to be a massive change in human behaviour. So already people love working from home. Who knew? It's become really, really normal. And so these people, they're all working from home. You know, people who normally would get on the train and will be exhausted and everything, and traveling, commuting, whatever jobs they're doing. So we're getting more and more people can be working from home. So in the past, all these people, for them to get to see a GP would have always been really difficult. Now it's going to be really easy. And not only that, it's going to be a fantastic excuse to get out of the house and go and have a chat with the GP. So I don't think things are going to get less. And in my 25 years, anytime anything changes in general practice, whatever it is, it always seems to increase workload and not decrease it. The behaviour of people seems to be, actually, you know what, I want to go and see a GP. Yeah, so I think it's a mug's game to predict what the future is going to be like. But I think we need to be open to what's going to drive it as possibly human behaviour, as it always does.
I think that's a really interesting point that you bring up, and certainly the work and the different changing of work, and in particular, and Brigitta's brought up here this appreciation of risk when we are dealing with people more remotely, dealing with people on the phone, and she's put here the concept of bringing a patient in actually adds an additional layer of risk, as an additional layer of potential problems for us. Because ordinarily they would have come to us, and we've got to decide whether they are safe to manage at home with potentially limited information, and protecting us has become a really important part of that. How have people been managing that? Sonali, would you like to address that?
Yeah, so I think, as I was saying, I moved to London in January 2020, so just before COVID. So I started in a new practice, and bearing in mind I'd been practicing as a GP for the last 11 years. Perhaps the risk-taking capacity, not knowing the patient's background completely or not having had the time to read their entire notes, meant my conversion rate from e-consult to a telephone or an e-consult, or then a telephone to a face-to-face, was far higher than than some of the other people who had been in the practice for much longer than me. But I think that I didn't let that faze me. I think what it was going to be not just an individual decision. It has to be about shared decision making, and you have to have that shared decision with your patient to see, this is your problem that you're presenting to me. This is what I think is potentially what may be happening, but we may not know completely. Can we set them off on a journey towards diagnosis? So I think it's important to realize that the online consult shouldn't be taken into something which is just on its own in the side. It has to be a continuum. So we had all started doing a lot of telephone consultations even before COVID, isn't it? So it could be that telephone or the online consult is the beginning of that diagnostic journey. So you started them off within the online consult. You've then decided to bring them in because you want to examine them. You've taken them forward for some investigations, and then maybe the follow-up is through a telephone consult again. So I think we should not try to separate them out separately. In terms of the risk, I think bring it back to the patient always. I think if you're able to do that shared decision making, that risk sharing, then you will come to some sort of common a plan that both of you are going to be comfortable with, and you're not going to be carrying it home. That's the most important thing for me. I think if while doing a consult, I feel this is going to be something I'm going to lose sleep over, then let me put that out in front of the patient. Let's come to a plan and what next steps we're going to take.
Fantastic. I think that shared decision making is something that I've really identified with over the last few months, and I think that, and again, one of the potential positives of this COVID situation we find us in is that shared decision making, that sort of patient-centered, patient-negotiated care is really come to the forefront. Although I think I really agree with everything you said there, Sonali. Although it does link in with Jodie and Richard's comment there about the workload that is associated with that. And if we are taking people from the start of their healthcare journey, whereas face to face we might have dealt with it in a single, well, I'm going to say 10 minutes, but 15 or 20 minute consultation. And if we are looking at doing this sort of multi-stage, actually, is that a greater amount of work? Is the additional safety netting, additional layers of risks, things that we need to address? I suppose in a similar vein, do we feel like these, similar to what Richard was saying, do we feel like the model of general practice that we have at the moment, sort of overall of, clinics and the like, is likely to evolve going forwards? Do we think that the morning and the afternoon surgery is going to be a thing that we continue, or a thing of the past? Anybody have any thoughts there? It's a pretty open question. Matilda.
I don't necessarily think the model needs to change because we've had it for so long. It doesn't mean that, we can't edit it to make it better. But I think in order for telephone to be sustainable, I think we need to think about how the appointments are being booked. So there kind of needs to almost be a pre-triage. So, things like skin rashes, I just want another repeat of my medication, those kind of things, really straightforward. If you get the picture, or, if it's just a straightforward medication review, really easy to do on the phone. But when you start to get complex patients, or, patients, as I said earlier, who English is not their first language, yes, I can do a 3-way call, but even at that, I'm probably going to end up, and I have found that I tend to bring those patients in because I'm almost kind of a bit unsettled that I haven't got the grasp of everything. So I think maybe over the coming months, it's kind of looking at how we can filter things so that what is booked for telephone is appropriate. But the difficulty is, in a lot of practices, patients can go and book it themselves. And by the time you realize that it's probably not appropriate, it's either 10 minutes before the appointment or it's too late, you can't change it.
Great. That's really interesting thoughts there. Anybody got an alternate take on this? Anybody think that things are going to be turned upside down by this? Sonali? Oh, Richard?
Oh, I thought, Matilda, that was really interesting and really poignant. But it also got me thinking. Sometimes my mind wanders. I think about Trump, but I was actually just thinking about Matt Hancock instead, and his comments about how we all need to go digital first, and how completely unhelpful that was, and trying to be mandated by people to do stuff because they think they're talking to their voters, not actually to. General practice is so lovely and so enjoyable. It's almost an art form that requires you as a GP to be a really amazing listener, and to know and to find out and to be sensitive to the context of each patient. And when you do that, then you can then adapt your treatment, your management plan, and for them, and work with them, and come up with something. But we have so many constraints, and the constraint of e-consulting first, the constraint of the 10-minute appointment. Why is it 2020 and we still have that phrase in our dictionaries? We start at 9 o'clock in the morning, and by 9:10, all of us are stressed because we've already started running late, and that's it for the next 12 hours every day. Why? Yeah, and that has an impact on the patient, and I think, about nice thing about being GPs, if we possibly can, is kind of take as much control back of that as we can, and instead of having to do this scattergun approach of all these constraints, it just ends up having to do things multiple times in a very inefficient way. Is have the ability to. I don't know, I'm waffling now. I don't have no idea what the solution is, but that's what Matilda got me thinking about. Thanks, Matilda.
Yeah. That's great. And it's one of the great things about these sort of discussions. Sonali popped in the chat here this the multidisciplinary approach and seeing more complicated things. The 3.5-hour session isn't sustainable. I certainly agree. I sometimes wonder whether we are doing a 3.5-hour session. I mean, what do you think? What do you think that we can do about that going forwards? What do you think that the RCGP might be able to do to help develop that? Is there anything that we could?
So I think there was and I'm trying to remember, the Future of General Practice, the document that was produced, and I remember coming to my CCG and saying, it's in this document that we should have 15-minute appointments, isn't it? And then they said, and what are they going to do about it? Where's the funding going to come? And that's keeps coming back to that, isn't it? How do we manage the workload there is no contractual requirement on us to do 10-minute appointment, when actually when I moved to this practice in London, they did have 15-minute appointments, and we still continue to have the telephone appointments as 15 minutes. There's another model which has, so I think 3.5 hours, I really, and also I think with, during COVID, at least my attention span certainly has gone down, greatly, and I'm sure it's happened maybe with the others as well. So I don't think 3.5 hours is actually sustainable. I see it more as a 2.5 hour with our multidisciplinary team approach. So you have to remember that you may not, depending on the other additional roles that you may be working within your practice or within your wider primary care network, you may not be seeing the minor illnesses, and you may not be seeing, hopefully you're not seeing the self-resolving illnesses as well. That means what you may be left with is providing that personalized continuity of care, which requires time. And you may be working with the other members of the multidisciplinary teams. If I give you an example, I used to do the care home in Nottingham. I used to be the care home lead GP, even though there wasn't a requirement within, at that time, within any of the national contractual requirements. But I used to really enjoy it because we had the multidisciplinary team approach over there. We had a care home specialist nurse. We had the physiotherapy, the OT, and the dietitians. So even though I used to spend an entire afternoon there, which was a care home for 64 residents, it did not feel that tiring because it was not just entirely my burden to carry. It was really the right person doing the right job. So it was not me trying to manage, falls related to multiple reasons in an elderly person. It was the physiotherapist, it was the OT, and it was the dietitian. And I think that's where we'll probably be moving to, that if we have all of these additional roles within the practice, then we really do give it a team approach where you've got the link worker as well helping you with providing a more holistic approach, and you've got the pharmacist as well looking at all your medication interaction. So to me, at least, the way I see it is that we maybe a day split into kind of 3 chunks of 2 or 2.5 hours each, where you actually have time in the middle to do your admin as well. It is time accounted for. If you currently have a session of 8 to 12 and then 3 to 6, 12 to 3 just goes by, not because we're just sitting and having a chat, but because of the admin, overload. And it will only increase, I think, because of more complex patients. So I think that needs to be taken into account. You cannot just imagine that work has to be done by someone somewhere, but equally, then we may have trained some admin staff to be able to do the document management, your pharmacists are doing with medication, but it may require that supervision and overseeing by general practice. But I think all the time needs to be accounted for. And hopefully in the new appointment system that NHS Digital is looking at, they'll take that into consideration.
It's really interesting you say that. One of the questions that came through while we were talking about that is, one of the reasons someone wanted bigger GPs so far was for the work-life balance. But do we as a panel foresee that general practice might go to 7-day work schedule with sort of 7 weekdays? And I know it was sort of a topic or something suggested by the government a few years ago. Any thoughts as to whether we might end up in that situation? Jodie, do you have any thoughts on that?
I think outside of medicine, if we think sort of multidisciplinary and across other industries, the way everyone is working is changing. So my husband works in comms, completely different field, but they're now all working from home. So actually quite often, if someone is going to be away with their kid on a Wednesday afternoon, they might do a Saturday morning, and that works for them. So whether we go to a 7-day working week, we may well do. Does that mean that if you want to work Monday to Friday, you'll have to cover the Saturdays? Probably not, because actually there's a lot of people that they would much rather have a day off during the week and do something at the weekend, and it works with their home life. So I think that it's possible to have balance without working Monday to Friday. And I think we have to try and stay a little bit flexible in our thinking sometimes when the introduction of weekend working might come in. And it probably will when we look at how everything else has kind of gone 24 hours across every other industry. But trying to stay positive to that and say, well, actually, it might work better for some of us. A lot of my friends who've just had kids in similar position to me have actually all have gone to out of hours because they'd much rather be with their kids when they're awake during the day and then go and do an evening shift and finish at 11 p.m. or 2 o'clock in the morning and be there again for breakfast. So yeah, if it's not for you doing those hours, I would like to hope that our workforce is diverse enough that actually the hours that suit the right people will be the people working in those hours.
Brilliant. Really interesting answer there. And I think that the support that surrounds that and the support in and development of systems, development of workforce is going to be core in that. And of course the new GPs coming up through the system, First5 GPs I'm sort of talking about, again, are going to be instrumental in helping to shape what that looks like and to make sure it's fair, equitable and suitable for for us, because a newly qualified GP is going to be a GP for the longest possible time at the moment until the next year comes along. So I can appreciate we're approaching the end. Just one last one, really interesting question here though. So someone's planning on becoming a GP. Welcome, please come and be a GP. It's great. What's the future of GP training look like? And how do we think we're going to end up with that supervision? Richard, do you want to take that one? We got 1 minute though, so a very quick answer.
Gosh, it's been 25 years since I did my training. All I would put a plea in for is to so many of us, up to 50% of newly qualified GPs work as locums, and to get some sort of introduction training, induction into not so much the fact that as soon as you qualify you're going to be working in a practice with a fixed team in a fixed building where you know everything works. No, when you first become a GP, you could be working in 2, 3, 4 different surgeries in a week, different systems, different processes. You need to know that there is stuff you don't know. Don't go in thinking you know stuff. It's a massive learning curve. There's so much you don't know that you don't know. And I think training could really help a bit more with that.
Brilliant. And I think I would agree with that. And I think that it is going to change and it's going to develop. Jodie, again, do you have something you want to add
Very quickly, yes, I'm a GP trainer, just finished my GP trainer training. And to the chap whose name just disappeared, who wants to go into training, you will never meet a more motivated, interested educationalist group than a bunch of GP trainers. It's been a joy learning alongside them and having a mentor in GP training, and they're working really hard to make sure that you can still get beneficial training in this changing time, whether that's on the telephone, whether it's remote. So please don't be put off by this. You will have a fantastic mentor somewhere in your training that will look after you during this difficult time. So please don't let COVID put you off applying for general practice.
Excellent. Thank you so much. So very, very quickly, and again, it was what we intended to end with. So I'm going to ask everybody for a 15 seconds, single sentence, because this is all about the future. And if I could ask you just one thing would be, where do you see general practice and the role of the GP in 20 years' time? And it's a big question. So challenge here, one sentence from each of us. Richard, you're unmuted, so I'm going to come to you first.
I think focusing on those who actually really need it the most.
Fantastic. Brilliant. Concise. Matilda.
Just based on the study that was done, maybe patients choosing the length of their appointment. Apparently they're quite good at getting the right time.
That's a fascinating point for discussion. We should come to that on another webinar. Please, we'll come back to that one. That's brilliant. Sonali.
GP by choice, not by chance, and working in a multidisciplinary team.
Absolutely. Great. Jodie.
Using a phrase from something that I was completely against, but Brexit, take back control. So I hope that as GPs, we can actually take back control of what's been happening in general practice and make it work for us and our patients. So a positive take back control, not a Brexit take back control.
Absolutely. Thank you so much. Really great statements. And we'd love to do some more about this and discuss these things further. So without further ado, because it is bake-off time, thanks to everybody for coming and to our wonderful panel tonight. Thank you to Sonali Kinra, Richard Fieldhouse, Matilda Esan, and Jodie Blackadder-Weinstein. Thank you so much for everybody coming and attending this. It's really good to be able to connect with our members and connect with people in the RCGP around the UK and further afield. Thank you for questions. If you have any more, please email Bryn. Please get in touch with the college. Don't forget to access the other GPReady content we have, either by searching hashtag GPReady or heading to the rcgp.org.uk/GPReady. We've also got a load of First5 resources. Get in touch with the local First5 network. We would love to meet you and engage with you and support you. We also really appreciate your feedback. So to make sure these events are as good and engaging and as frequent as we can make them, and to really engage with you guys. So after this, there'll be a short survey. Please fill it in, just a few minutes of your time. Fill in the white boxes. They're the most helpful with your real opinions on what we as a college can do for you. You can share your thoughts about it and just communicate with us. It's a two-way street. So from the panel and from me, thank you so much for coming. Thank you for giving up your time. Hopefully this has been helpful. Hopefully there's been a few takeaway messages, and the future is bright in general practice. Thank you for coming. Enjoy the rest of your evening, and we'll see you soon. Thanks.